Welcome back to Long Covid Doctor, an educational series for Long Covid sufferers. I'm Dr. Tim Robinson, formerly a family doctor, GP for 30 years, now working in Long Covid Services for 5 years. I post on podcast channels and YouTube. Hope you find my postings helpful. If you do, click subscribe, spread the word. Let's get it out there. Thanks for all your feedback. And apologies, I don't have time, I'm afraid, to reply to all of your helpful comments and suggestions. But I appreciate them all the same because it helps me with my future postings. So keep them coming. Another apology, important though, my usual disclaimer, any advice or treatment that I mention should only be considered after discussion with your own doctor. So, this talk is all about headache in long COVID. So I've divided it up into two parts to make it less overwhelming, less tiring. In part one, I will cover headache and what our patients are telling us, bearing in mind that, as I said, I've been working with long COVID patients and long COVID services for 5 years, so I've heard a few stories. As I said, I want to know what the causes are as well and the explanations about the long COVID headache. So that's part one. So part two will be sort of the treatments and strategies that we can use to try and help and treat those headaches. So here we go. Headaches in long COVID. So what are our patients actually experiencing? What are they telling us? So a mixture of symptoms really, sort of pain, headache pain, be it on the top of the head, the vertex, the skull cap type headaches, or a band around the sort of the forehead and across the temporal area around to the back, or in the neck, tight shoulders, neck, and extending up to the base of the skull. Headaches can be sort of on one side only, unilateral, or both sides. The headaches are either continuous, there all the time, or on and off, coming and going. Some patients describe a sort of a continual background headache, but then from time to time, and more often than not, quite frequently, they have flare-ups of their headache, an exacerbation, a worsening of their headache, which stays with them for a period of time, and then it dampens down to that background headache. Also got a group of patients and a big group of patients who have a past history or still ongoing migraine. So this migraine tendency. And they find, since having COVID and now long COVID, that their migraine has got completely out of control. Much worse than ever before. And it's no longer controlled by the medication that they are taking. And with that migraine, their migraines, they obviously have a return of their associated symptoms. And so that feeling of sickness, nausea, and fear of the light, photophobia, that premonition that they're going to get a migraine attack, what we call an aura. And that could be visual aura or a auditory aura or even an olfactory aura. They smell a sort of strange smell and they know, I think a migraine is coming. And the other thing that a lot of my migraine sufferers experience is visual disturbances. They fall into two categories really. Or the two commonest are a sort of almost like seeing a sort of a jagged line, like a lightning bolt, a bolt of lightning, sort of in one part of their visual field. Also, they see what's known as fortification phenomena, where they see sort of fortifications like the top of a castle, the sort of the blocks between which people peek through. So sort of a grid-like block sense disturbance, visual disturbance. So those are all the associated symptoms, but more often than not, it's sort of this terrible migraine headache that they have. And again, it's classically one-sided, but it can be both sides, can be either classical or common migraines. So one-sided is often a good telltale for a migraine. So that's what our patients are experiencing. Like I said, a new onset type of headache, or a headache that is their migraine that's coming back. So what are we going to do about it? Basically, anything new, any new symptom, thing that's affecting your health, what do? You go to your GP, don't you? And that's what you should do. And you need to report that thing that's different, that thing that's new, okay? Even if you're familiar with it, but if it's out of the ordinary and it's a new sort of element to that previous symptom, I think you ought to just run it past your GP, either phone call, consultation, or face-to-face. The reason I'm sort of mentioning this is that actually we mustn't be, and I've said this before in previous podcasts, we mustn't be COVID blind. And what do we mean by that? We mean that all because you've had COVID and that's become long COVID, you have long COVID, and then you also have a new symptom or a new sign, something that's different in your health status, then it's very tempting to say, all right, I've got long COVID and I've got this new thing, it must be related. Yes, well, it might be. However, it might not. But so, it might be just coincidence. So we don't want to sort of disregard something that actually potentially could be worrying, could be more serious, and sort of hence dismiss it and then delay going to seek advice. And then, with a delay in advice, there's a delay in diagnosis, then we might miss something. So we need to be aware of this, and if there's anything new that's worrying you, take it to your doctor to get it checked. Remember, safety first. And when you get to the doctor, what is the doctor going to do? Basically, it's going to listen to your story, hear the symptoms, all those relieving factors, exacerbating, worsening, trigger factors. It's going to ask associated questions, probably examine you, depending on what you've told the doctor. And in this headache context, then the doctor will probably do a few sort of neurological examinations. Probably just a sort of a quick run through of what we call the cranial nerves, the main nerves to do with the head and neck. Just run through that, and just to make sure that they're all present, working normally. There's no sort of asymmetry. They're all the same and balanced. The doctor may also, if you're saying that your headache is sort of like at the base of the skull, at the back of the skull, the occiput, extending down to the neck, the GP may well say, right, let's just check the neck for the range of movement. Is it fully to the left, fully to the right, up and down? Is there something caught, in the what we call the cervical nerve roots? Are they being irritated on one side more than the other? So, examination, simple examination, looking at the range of movement of the neck will tell the GP this, and hence direct the GP as to what to do next. The GP may feel, actually, not a lot going wrong here, and, can't find any sort of abnormalities on examination. Maybe I'll do some blood tests just in case, just do the blood panel, looking at the red cells, looking at the white cells, just in case something's got through, maybe the thyroid function, maybe your diabetes markers, if looking for something called the HbA1c. Some simple blood tests that you can do, routinely. No harm in checking. One of the fears that a lot of patients have who have a headache is they ask that question, my goodness, is this a sign that I've got a brain tumour there lurking and it's sort of growing and causing my new onset headaches? Well, right straight off the bat, I'll say that headache is an extremely rare presenting symptom of brain tumour, which you really must register that, okay? So an extremely rare presenting symptom. The commoner symptoms are neurological deficits, something that's not right, neurologically, or there's an imbalance. So in other words, because the patients are worrying that they might have a brain tumour, then the next question really is, can I have a skull X-ray, please? Or the one after that is, or maybe at the same time, is, can I have a scan of my brain, please? The patients may have been doing some research, long COVID research, and I wouldn't blame them. If I had long COVID, I'd be doing lots of research, trying to help myself get better. One of the bits of research was on patients who had the acute COVID, so the actual COVID infection. There was a paper published very early on in the sort of the 2020-2021 of a group of patients who'd had MRI scans prior to COVID. This is the UK Brain Bank study. And then they'd had their MRI scans repeated after they had their acute COVID. What they found is that these patients had differences in their brain, in the inflammatory tissues, the microglia, the microthrombi with little mini blood clots were seen, but also parts of the grey matter, those are the cellular parts of the brain, were shrunken compared with those patients, compared with when they had their scan prior to the acute COVID. And interestingly enough, it was the grey matter, the nerve cells in the areas of the brain which are focused on the short-term memory, so the hippocampal area, but also the prefrontal cortex, the orbital frontal cortex, which is the area for executive function. So we know that other symptoms of long COVID is brain fog, cognitive impairment, and the two main features of that are sort of executive functions, decision-making, processing, etc., but also short-term memory, which is where the hippocampus, that's when that happens in the hippocampus. So that was interesting. So a lot of patients may have seen those studies and think, oh my goodness, I wonder whether I have got these changes in my brain. So reasonably they ask, their GP, can I have a brain scan? It's quite controversial because we only do investigations in medicine if that investigation is going to change the management of that patient and that patient's condition. So finding these changes in their microglia and their grey matter, as I've been talking about, will that change things in the way that we manage that patient? That's in a way the most important question, because if it's not going to change the way we manage you, then actually there's no need to do an MRI scan. Plus also MRI scans can throw up sort of, if you like, a few sort of false negatives and can be a bit misleading, and then hence raise raise anxiety levels further. So, I mean, and the other thing is, if everyone with long COVID was given an MRI scan, we'd be looking at, certainly in the UK, 2 million MRI scans. For what gain? And so, I think that it's only unless a specialist requests an MRI scan, I think it should be left to say a neurologist to decide that. The other thing that when you visit the GP is doing is basically looking for those red flags. Those are the symptoms or signs that are indicative of other more serious conditions that may need referral onto a specialist. So red flags that GP would be looking out for would be in the neurological examination, looking for one-sided weakness, for example, or one-sided loss of sensation, or difficulties of speech, or sort of asymmetrical facial features, or new onset difficulties with balance and coordination. Those would be the red flags that a GP would be very much looking out for, because they could be indicative of something more serious happening neurologically. Getting back to the sort of the headache aspect and thinking red flags, another condition that a GP would be thinking about for those patients who are bringing to them a one-sided temporal headache would be temporal arteritis, which is inflammation of a single temporal artery. So we'd be looking out for this, because this is quite serious, because if it is allowed to progress and go untreated, that can lead to blindness in one eye. But it's really very serious, and it's very, very serious as well, yeah, but severe and really tender. The actual blood vessel, the temporal artery, if you can prod around and you can feel your temporal artery pulsating, okay, that is excruciatingly tender. And that's, very, very different to the type of headaches or migraines that we're hearing in the long COVID clinics. But that's a red flag. Also, the other red flag is the sudden onset of a severe headache, particularly around the back of the head. The GP would be thinking, gosh, that could well be what's known as a subarachnoid hemorrhage. But again, in our context, in our long COVID context, it's not really relevant, because the headaches are sort of, they're not sudden onset. They're there all the time. They've been there over a long period of time, protracted time course, etc. So it doesn't really fit into that category of sudden onset subarachnoid type headache. And the temporal arteritis, it doesn't really fit into that, because the patients aren't bringing that to us, this tenderness of the temporal area. So anyway, needed to flag that up, those red flags, as what a GP would want to be looking for and excluding, ruling out. Again, all the time looking to make a diagnosis, okay? Any of those worrisome things, obviously, the GP will be sending you on to a specialist. So having ruled out those other causes for headaches and the red flags, we're left with headache due to long COVID. Well, what are the causes for that? Are long COVID headaches? Well, first and foremost, there are a number, of course, because we remember, long COVID is a multi-causal, multi-system, multi-symptom condition, annoyingly. So, a multi-causal. So there are lots of causes for headaches in long COVID. First of all, and probably the commonest cause throughout long COVID, is inflammation, ongoing inflammation. Inflammation in the tissues within the brain, yeah? So the nerve tissues, for example, they may have been damaged by the acute onset of the illness, the actual viral infection, damaged or even destroyed from that infection. Because we know that the virus can get up the nose and then along the olfactory nerves, the nerves that whose function is for the sense of smell, and into the brain, into what's known as the olfactory bulb, and then into the centre, the heart of the brain. Okay, so inflammation can get in that way. Inflammation can get in because the blood-brain barrier has been damaged. Again, that's something to do with the blood vessels that make up the blood-brain barrier have become inflamed, and they are leaky and allow inflammatory factors, inflammatory mediators, cytokines, into the brain and causes inflammation. So that's inflammation of the nervous tissue. I've talked about blood vessels getting inflamed, the endothelialitis causing the damage of the blood-brain barrier, but also in the blood vessels there is the micro blood clots, the microthrombi, which then have caused occlusion of a number of different, or many different, very small blood vessels within the brain, and we can see this on both perfusion studies but also scans. Another offshoot of excessive inflammation in the brain is the activation of the brain's lymphatic system, its own immune protective system, the microglial. Okay, again, we see this on MRI scans where the microglial is activated, and then an active inflammatory tissue, lymphatic tissue, is going to cause an effect on the functioning within the brain. Another offshoot of inflammation is activation of mast cells. And I've talked about mast cell activation when I talked about the gut on the gut podcast, and I've also the podcast in mast cell activation syndrome as a standalone podcast. I talk about activation of the mast cells. Well, what we do know is that there are lots of these mast cells that are surrounding what's known as the ventricles within the brain, and they are quite intimately related to the limbic system, which is made up of a number of components. The amygdala is one, which is the sort of the anxiety, fear-locking area. Also the hippocampus, and it links in with the hypothalamus and the pituitary gland, etc., and the prefrontal cortex. So activation of those mast cells, releasing the histamine and other inflammatory components, will basically lead to inflammation in the brain. And finally, autoantibodies. So again, we have found antibodies against ourselves, our own normal nerve tissues, our own normal blood vessels, and our own normal connective tissues that link all this together. So inflammation is a big problem and is probably the biggest cause for headaches related to long COVID. And like I keep saying, this what I've described and outlined here is all measured and proven and published, etc. These are all facts. So, a headache with long COVID could be any one of those, or it could be a number of those. It's probably a combination of all of those to varying degrees. There's no reason why it shouldn't be. Other causes, having done inflammation, other causes in long COVID, there's dysautonomia. We'll again, podcast on dysautonomia, look at that. But basically dysfunction of the autonomic nervous system, that imbalance of the sympathetic from the parasympathetic nervous system. Brainstem damage as a result of this dysautonomia, and also the sickness behavior response. This is something that we've all had. We all have. It's natural. That it comes from the brainstem. When you have flu, you feel sick, don't you? You've got your temperatures and you've got your headache and you've got your achiness and you feel unwell and you're lethargic and you've got fatigue. Sickness behavior response. In dysautonomia, because of long COVID, then that triggers the sickness behavior response. Again, another cause for headache in long COVID. And then another offshoot of this dysautonomia, basically this imbalance of the sympathetic and the parasympathetic nervous systems, means that the blood vessels throughout the body, but here we are talking about the headache in the brain, are not functioning so well. They're not responding so normally. They're not opening and closing when they should. So all blood vessels in the body are not sort of fixed in diameter. They are either enlarged, so dilated, or they're contracted. Okay, and they expand and contract, dilate and contract according to the need. So when you're going to do some physical exercise, the blood vessels in your muscles will open up. They'll dilate to push more blood to the muscles, more oxygen. Okay. Headaches, migraines are very much associated with problems with changes in responsiveness of blood vessels within the brain. We know that. Moving on from dysautonomia onto central sensitization. Now this is a strange condition which occurs in lots of different conditions in medicine. So it contains in what we call sort of fibromyalgia, for example. It can occur with endometriosis. It can come in. It be part of the regional pain, complex pain syndromes. It is something to do with how impulses from painful areas, inflamed areas, or not painful areas could be coming from anywhere in the body, are processed in the brainstem, in the pain center in the brainstem. And basically, there's an oversensitivity to those impulses coming in, or there's a misreading of those stimuli, and particularly painless stimuli that come in, and then the brain, if you like, scrambles it and puts it into it reads it wrongly, and then that registers as chronic pain. So these headaches that in long COVID, there may be an element of central sensitization. A couple more, then we've finished it. So basically, when you've got a headache, what do? You take a paracetamol, don't you? Yeah? Okay, so actually you can have too much of a good thing, in that if you have paracetamol, the full 8 a day, 2-4 times a day, for more than 15 days, this is what the neurologists tell us, more than 15 days in a month, then you can get analgesia overuse headache. Okay, so be aware, if you take too many paracetamol, that can backfire and actually exaggerate the pain, the headache pain that you might have, or anywhere else in the body that you might have pain. And finally, tension. Due to, tension. I talked about, tension, if you've got a headache in the occiput, at the back of the head and extending down the neck. That is often a sign of tension, isn't it? And what goes with it is a band of a headache, a band-like headache around the forehead, across over the temples and back to the occiput, the back of the head. That is your classic tension headache. Now that may become because of something's not quite right in the neck, and the neck's tight, and the muscles, and some cervical nerve roots suppressed, etc. So tension for that reason. Or it may come because of stress and worries. That is natural in long COVID, in anything that's not right, okay? When we're worrying about something and stressed about something, what do you tend to do? Your shoulders tend to go up and you tend to get all tensed. And then that can cause pulling of what we call the fascial layers over the skull, and that leads to a tension headache. So, it's just another cause for your headaches. But like I said before, with the inflammation, you could have a little bit of everything, and there's no reason why you shouldn't. And that's what happens. You can have a little bit of everything that all contributes to your problem of that headache. So I've gone on about causes a lot, and I always do, and I think it's important to, because it's important to know the causes of your symptom, in this case your headache, your long COVID headache, and because it helps you with sort of validation, and to know that the causes have a reason behind them, that they are real. They're research evidence. I keep saying this, that's backed up by studies and published in journals and things. It's, these are a real thing that have been present whilst you've had your long COVID. They're not imagined. No, these symptoms are not all in your head. You have not imagined them. Understanding is also important for acceptance. Understanding brings peace of mind, let's face it. And also it sort of relieves those worries and niggles that you might have. And that in turn helps us with the management and the sort of appropriate treatment. Sensible, appropriate, proven treatment. And overall, that helps with the expected outcome. So, there we are. That's part one of my talk on headaches in long COVID and what our patients are experiencing and their causes. So in part two, I'll talk about how to tackle them and the treatments and the strategies. So, see you there. All the best. See you soon.